So, good evening, ladies and gentlemen. My name is Stefano Rossi, and I'd like to welcome you to the EKS Hot Topics, the edition of May 24. The topic for today is biomarkers and PJI diagnosis, and we have a great faculty. Let me introduce Dr. Vicente Leon Munoz from Murcia, Spain, who's going to be the speaker for tonight, and the two challengers, Gijs van Ellemont from St. Martin's Clinic in Nijmegen, the Netherlands, and Federica Rosso from Turin, Italy. My co-moderator is Professor Sébastien Lustig from Lyon, France. And let's go straight away to the speaker. Please, Vicente, start. Thank you very much for being with us tonight.
Thank you. Good evening. It's a pleasure to introduce this topic of the use of biomarkers, molecular tools, for the diagnostic of periprosthetic joint infection. I was born in 1968, the same year that Kubrick's 2001 A Space Odyssey was released. I read somewhere that one interpretation of the film could be that we are human because we are intelligent. That intelligence is our defining characteristic and primary tool, and we should make the best use of that intelligence. We are at a point with periprosthetic joint infection where we must squeeze our intelligence because periprosthetic joint infection are really a problem. As you all know, periprosthetic joint infection occurs in 1 to 2% of primary and 4 to 10% of revision arthroplasties and is increasingly concerning. And we have a problem because we are improving on non-infection causes of replacement, but not on infection revisions. We discussed this problem last April at the 4th World Arthroplasty Congress. Dan Barry from Mayo Clinic pointed out that infection is an unsolved problem in joint replacement surgery. In the last 30 years, we have not got any better at preventing infections. On the contrary, we have got worse. Periprosthetic joint infection not only significantly impacts patient quality of life, but also represents a significant health and economic burden to the system. In addition, periprosthetic joint infection has non-negligible mortality rate. And we have some problems with its diagnosis because an appropriate etiological diagnosis is necessary for adequate timely surgery and for targeted antibiotic chemotherapy. And sometimes we don't get that etiological diagnosis at all. In addition, periprosthetic joint infection, especially in chronic cases, can sometimes be difficult to diagnose with first symptoms, with negativity of reactants, and without bacterial detection. Different diagnostic guidelines of definitions of periprosthetic joint infection had been proposed. The most recent, published in 2021 by the European Bone and Joint Infection Society, proposes the terms unlikely, likely, and confirmed infection. But sometimes we continue to accept, as in previous guidelines, that diagnosis is a combination of elements. We have several serum and synovial fluid biomarkers with different sensitivities and specificities. Some papers highlight the usefulness of alpha-defensin and leukocytes rather. In many cases, we have nothing that guarantees us 100% of diagnosis. And we have still false negatives and false positives. Another issue. In periprosthetic joint infections, time is essential because the biofilm is a dynamic concept, not an static one. Indeed, we have a problem. Various molecular biology-based alternatives have been proposed to solve this problem. Polymerase chain reaction is a common laboratory technique used to make many copies, millions of billions, of a specific region of deoxyribonucleic acid. The polymerase used is Taq polymerase, isolated from the heat-tolerant bacterium Thermus aquaticus. That polymerase is ideal for the PCR because of its thermal stability, as the reaction requires high temperatures to denature the DNA template or separate it in strands. Suppose we have a minimal amount of deoxyribonucleic acid from a contaminating germ in a tissue sample, a synovial fluid, or in a sonicated prosthetic fluid. The basic steps of the PCR of the polymerase chain reaction are the thermal denaturation of the DNA, resulting in single-strand templates, recognition by the primers of the complementary sequences, extension of the primers by the Taq polymerase, and synthesis of the new deoxyribonucleic acid strands. And this cycle is repeated, amplifying the DNA to millions of copies. And by using different strategies, we can have a semi-quantitative or a quantitative method and determine the amount of PCR product. Custom-made methodologies based mainly on 16S ribosomal RNA or DNA, amplification and sequencing have a high sensitivity and specificity, but they are currently practically not used. Many pharmaceutical companies have launched multiplex polymerase chain reaction techniques, including most of the microorganisms causing periprosthetic joint infections. And this multiplex PCR has been used to identify microorganisms and detect resistant genes, with multiple studies demonstrating their improved sensitivity and diagnostic efficiency compared with our habitual culture methods. Despite these relative good results, they are not used in most laboratories beyond experimental studies, not in clinical. Due to the cost, due to the need of for specific primers for sequencing, due to problems of logistic, and due to the absence of detection of some germs involved in periprosthetic joint infections, and also due to worries about the clinical significance for diagnosis or even concerns about false positives. For example, the Bio5 joint infection panel identifies 39 pathogens and antibiotic resistance markers at the molecular level, but does not detect coagulase negative staphylococci, apart from Staphylococcus lugdunensis, and not detect Coutinobacterium acnes. The next generation sequencing are not a thing of the future. They have already arrived on Amazon. They are molecular techniques available for clinical practice that avoids some drawbacks of polymerase chain reaction-based methods and allow the detection of non-culturable, non-viable, and unsuspected organism in a single specimen. Some authors have suggested that 16S ribosomal ribonucleic acid sequencing has increased sensitivity compared to traditional cultures and to the newer multiplex PCR techniques. The metagenomic next generation sequencing has reported improved sensitivity compared to the traditional culture, demonstrating something very important is the ability to isolate the infective organism in up to 82% of culturally negative cases. And another step is metatranscriptomic next generation sequencing, an RNA-based sequencing method that provides a deeper insight into the clinical relevance of the identified organism in any given specimen by determining active virulence and antimicrobial resistant mechanism. Some molecular methods circumvent the technical difficulties associated with cultural methods and enable pathogen identification despite prior antimicrobial therapy without compromised sensitivity. Remember, we have a problem with diagnosing of some polyprostatic joint infections. Is next generation sequencing the case to the solution? One of the criticism of molecular methods is that they cannot distinguish between an active or a treated infection, as the genetic material can remain in the joint even after the bacterial cell lysis. Notwithstanding, some authors found that the presence of DNA correlated with the presence of RNA, an active infection. And based on these findings, they are inclined to assume that the presence of any deoxyribonucleic acid in patients with periprostatic joint infection could be indicative of an active infection. But everything could not be so simple. And we have a second problem. Until recently, we assumed that certain anatomical sites were sterile and that detecting any germs there indicated an infection. Well, it seems it's not an absolute truth, and that there is a microbiome in the joints that compels us to distinguish between normal organisms in a native joint and those that are pathogens. Are alpha proteobacteria, cultibacterium, and staphylococcus species in the knee natural or are they pathological? Could a dysbiosis of the knee microbiome also leads to increased permeability and allow other bacteria to thrive, ultimately causing infection? Can the immune system cells, such neutrophils and macrophages, transport pathogens between different sites? Is this film like the discovery of Helicobacter pylori and the initial lack of attention paid to the postulates of Barry Marshall and Robin Warren? What is normal and what is pathological? I think that this film does not end here. I sincerely think that this film has just begun. Thank you so much for your time and for your attention.
Thank you very much, Vicente. Great presentation. So I will leave the two challengers to start with burning questions on your presentation.
So may I start with the first one? Great presentation. It's clear that so far there are a lot of questions still unsolved on this topic. So we start with the very first slide about biomarkers. We know basically everything about alpha defensin, but do you think that we need a more efficient biomarker? And if the answer is yes, which one may play a major role in the future, synovial CRP, or there's any other calprotectin or something like that?
I think today we have the best option with alpha defensin, but in the next years, I think the biomolecular markers, based on the next generation, will be more accurate to the diagnosis of the periprosthetic infection. They will be better, and we have more specific and more accurate diagnosis of the periprosthetic joint infection. Okay, today we have this alpha defensin, and today we have more in investigation, not too much in clinical use. The use of PCR of this variants, of this commercial variants, because they achieve not a nice diagnostic in all the cases.
Yes.
And as I say today, yes, alpha defensin could be a good marker.
So, Vincenzo, if I may ask you a question, you nicely showed in the registries that you see a increased number of patients with an infection. That would probably mean that either we have an increase of infection or we do a better job in diagnosing it. If we look at the criteria you nicely showed from different societies, I think everyone is looking for the million-dollar question, where to put your money. So if you would have a normal practice and you start with 4, let's say, tests you would advise surgeons to do in the case of an infection, what would you start with? You have 5 points to give.
To start to the diagnosis of infection?
Yes.
Okay. I think the last option from the I think, let me quickly.
So I think
Yes,
most surgeons
yes, the last proposed from in 2021 from the European Bone and Joint Infection Society is very nice, because I think it's the first time they give us a very important Mayo criteria. With one criteria, we can say it's an infection.
Yes.
Okay, and we can have practically 100% of diagnosis of the infection. Before strategies, we need to take major criteria and minor criteria and have more problems to make this diagnosis. Today, I think this criteria from 21 are fantastic, but of course, we need their criteria to say we have a periprosthetic joint infection, but we need to know who is playing against us. It's not the same Real Madrid, Barcelona, than Murcia. Okay.
No, but I mean, if it's, for a surgeon, it's clear that if you start with normal laboratory testing, aspiration of the joint, I think the biomarkers will probably will not be in the first line of your diagnostic tools, as you showed. Huh?
Of course, I think today we all do the diagnosis of periprosthetic joint infection with a criteria of the last 10 years, and the culture is very important. We are speaking about these cases when we don't have any idea who is the microorganism causing this infection, and we need to know who is. We need to know the etiology of the purpostatic joint infection, because the result of our treatment can vary a lot. Okay, and obviously today, as in diagnostic of the infection, culture, and control with normal markers, I think we need to wait some years to have these new technologies, these new biological markers, to have a diagnostic. But it's the future. And today, some of these commercial kits, we have, by example, in our hospital, these commercial kits, and for the microbiologists, it's very easy to say, okay, in 25 hours, yes, in hours, they can say us it's still a staphylococci. And it's very important to have this information in really hours, and not days, and not weeks.
But the reason for my question is that I think we need to solve the problem of the culture negative infection as it is now, as you showed. So in most of the cases, you will find, let's say, the diagnosis of infection. And the problem, of course, as you showed, maybe somewhere in literature between 10 to 30% has a culture negative infection. And of course, there are a lot of companies approaching us with a perfect, let's say, biomarker, which is industrialized, where you have to pay for, which might solve a problem, but we are not sure about that. And as Frederica said, if you go back 5 years ago, it was interleukin 6. We have all these markers, but they were not, let's say, used in daily practice routinely.
I agree with you. Yes.
So my question is, if you want, we have just an amount of money and we have to decide in which technology we want to spend it. So would you go for the next gen sequencing? Would you think that this is the place in which you will put your money if you have to, bet on just one exam over the other, or would you prefer something else?
Yes, I think it's the really future of the next 5, 6, 7 years, and I will buy something to develop this, to increase accuracy, and to make it simple for the for our understanding, and to achieve in the cases that, as Gilles said, in the cases of negative cultures, it's very important to have the information of the principal bacteria that cause this purpostatic joint infection. And in this case, I think in the next years, this technology will be the most important, if they can control the cost.
Yeah, I think the cost, and also the false positive, probably, because if we are going to replicate so much, we may have some false positive, which is better than some false negative, but still a problem for the patient, probably.
Of course, but do you need to think in one advantage is we can have information of the bacteria after an antibiotic initiated treatment. This is very important, and we can get information from these systems about resistance, about really resistance, and genomic resistance, and that could be very important to the decision of the antibiotic therapy.
Yeah, sure.
So there's still a potential risk, as Frederica said, for overdiagnosing the false positive patients. If you have a more sensitive way of diagnosing it, that might be the risk. We have to wait for studies showing what the cultures will be in a patient who has a, let's say, non-suspicion of infection. Maybe they are also positive.
We have this second problem, as I mentioned, I comment. We have the problem of the identification of what is normal and what is pathologic.
Yes.
Until the last years, we speak only if we make a culture of a bacteria, of a joint, of a knee, it was every time pathologic. And what can we say about this future, about this microbiome that we can have in the joints? We have learned all every time in the faculty, and every time when we began with this of orthopedics, we learn joints are sterile. Are they sterile or no more? Because we are speaking about a lot of papers of 2010, of course, the first published by a rheumatologist, speaking about bacteria, normal flora, microbiome in the joints, and with a relation with arthritis reumatoid, with a relation with osteoarthritis, and all these things are very new. We have, I think, we don't have enough knowledge to discriminate what is pathologic and what is normal, and in this sense, we have a lot of risk of overdiagnose or diagnose with the wrong bacteria, periprostatic joint infection.
So, and if I understood well, basically the microbiome would be different in patients with inflammatory arthritis compared to normal patients. So maybe we may think also about different criteria for this type of patient for PJI infection, or not, because they are at risk, we know, but still probably we don't have a specific algorithm for this type of patient. What do you think about that?
Yes, we don't have an idea. We don't have an idea about this and about what microorganisms are causing the periprostatic joint infection, or the microorganisms that are normal microbiome constitutive of the knee, and what this hypothesis of the gut dysbiosis is very interesting, because in the future we I think we need to give antibiotics, preoperative prophylaxis antibiotics, and possible probiotics. Possibly we need to give probiotics to the patients to avoid gut dysbiosis and to avoid this transit of bacteria from the gut system, by example, in joint surgery. So when I was preparing this talk, I have read a lot of things that we need to open our mind, because we have a lot of facility to speak about alignment, about stability, about total arthroplasty, but these molecular questions are a little bit difficult for us to understand, and we need to go a step forward to increase our knowledge about these technologies, because in 5, 6, 7 years, I think it could be very important for the diagnosis and for the treatment, and for decrease this problem with the periprostatic joint infection that we have not changed in the last 30 years.
So I think your comment is probably very important, that you could use this technique also in a preventive measures. Huh? I tried with some of my patients to go to the infectiologist to see if probiotics use was useful in prevention, but I'm afraid I didn't get a positive answer for now. So I know it's done in general surgery, but not very much done in orthopedics. Huh?
Mm-hmm.
So I don't know if anyone has any experience with it.
I personally have no experience, but I hardly think that prevention will be another key factor in the future, as we have to solve the problem of the culture negative, but we also have probably to perform better in prevention and identify patients highly at risk, and those patients may benefit from some of those treatments.
So, but can we use the biomarkers, let's say, information to also do something preventive, Vincente?
I think no. And I think the prevention is better today than in the last 10 years, But we can identify the people that smoke. We can identify and control people with diabetes mellitus. We have better antibiotics. We give the antibiotics in the half hour before the surgery. We have better protocols, but we don't change the periprostatic joint infection. We do the things, I think we do the things better, but we have not this control about the 1 or 2% of the periprostatic joint infection, and if we speak of recent surgery, a little more. And I think this technology is not to give us to prevent the periprostatic joint infection. I think this technology will help us to be more accurate with the diagnostic in these cases that we today have no diagnostic of, no etiologic diagnostic. I think it's so.
Vicente, if I can ask a question, make a comment regarding his, comments about probiotics, and how, antibiotics change the microbiota, and we did a study with Tristan Ferry here, and it changed massively. You're right. When people get under antibiotics for periprostatic infection, you change everything, and that's why I totally agree with you. When we go to give antibiotics to our patients, probiotics are doing something to try to restore the microbiota might be very significant, and we are just starting to see some really nice publication on that, and it's I think I agree with you. We don't know exactly what we should be doing, and this might be one way to improve and to move away from these crazy numbers you showed us, that the percentage of unsolved issue related to infection remain the same or getting worse. It's a little bit concerned, because I was expecting this percentage to go down, at least. And from what you showed us, it's the opposite. So we should find a way, and maybe that's one of the way to enhance our patient, because we optimize them, but not for that. No.
But Seb, could you tell us a little bit more about the study you performed? Because I think that's very interesting for orthopedic surgeons.
Yeah, well, so it was a study to try to assess in the guts, what was going on with the microbiota for these patients.
Yes.
who have periprostatic joint infection. So they have specific drugs with very high dose, and you change massively. And then we all know that this barrier, natural barrier, is very useful, and we completely destroy it when we give them bone, targeted, or joint, targeted antibiotics, but they're also very active on the rest of the body. And then these patients, during this period of time when there's a super high dose of antibiotics, they are actually less able to defend themselves against other infection, and especially the ones coming from the guts. So
it means that for those patients, you now routinely give them probiotics.
So we started another study to try to see, exactly how we can treat them, some kind of secondary prevention in this condition. And I think this is in line with what you guys were discussing. It's secondary prevention. It's not primary prevention, but we are all working in centers where we deal with a lot of these patients, and I think this is relevant and might also explain some what we call super infection. When you have another infection with a different bug, maybe it's coming from a different location. Yes. So yes, maybe we should advise. And again, we are at the research phase, so I cannot tell you exactly what we should be doing, but we are working hard to try to define some protocol for that. So yeah, it's going to come.
Yes, and possibly all this new knowledge will change our protocols. Possibly will change the time of antibiotics, the time of giving antibiotics. Possibly will change the form of giving antibiotics, because if we alter with the antibiotics, we destroy the the normal microbiome, we can increase the infection. And possibly, if we have more information, we will change in the future all the actual protocols of treatment of antibiotics. What do you think about it?
I agree. My question was there is some. Do you think that, for example, if we are talking about extended prophylactic antibiotic, it may have an effect on this patient? Because in some center, there is this. You can do it for 2, 3, 4 days, or antibiotics and everything else, even after aseptic loosening. So, do you need revision? Do you think that it may play a role? Talking about microbiome and gut and stuff like that. Maybe we are doing worse than better.
I don't know if we do worse than before, but we are not doing it perfect. We have no satisfactory protocols for all the patients, and for all the patients, it can be not the same to give 12 weeks or 3 weeks or 6 weeks of antibiotics, and sometimes we give the antibiotic because we have a positive culture, antibiogram, and are we really sure that it was accurate? It was the only bacteria. Have we more bacteria? Have we more agents, more microorganisms causing this peripatetic joint infection? Sometimes we make surgery 1 time change, 2 times change, and all the things are perfect, and we have a definitive solution for the infection. But I think we have some cases that we have a peripatetic joint infection, and a second peripatetic joint infection, and a third peripatetic joint infection, and the bacteria change. And every time it's more difficult, every time it's more complex, every time we give more antibiotics, we do more things in the open theater, but no solution. In these cases, I think these biomarkers have a change to give us information, and these cases are very complex, and we all have these cases, and we need to increase our knowledge to work possibly more with the people that control infections, and as Seb said, to go to another aspects, like the gut dysbiosis aspect, control to better identify these patients and to better treat them. Okay. Because
so
I think it's not
to come back to your question, Frederica, there are 2 problems, of course. Sometimes if you do a standard workup and you go into surgery expecting a aseptic revision and you got unexpected positive cultures. If you get that, I mean, we published on that in the Bone and Joint a few years ago. If you just treat them like you are treating an infection for 3 months, you do fairly well. The other problem is, of course, if you give everyone who has a aseptic revision a prolonged period of antibiotics. We did a randomized controlled trial, which will be presented at the EFORT, of over 800 patients in hips and knees. And there's no difference if you give them 1 antibiotic gift before the surgery and an extended, let's say, antibiotic period until the preliminary cultures are known. So it means 5 days. Those 2 patient groups, they do similar for hips and knees. So there's no potential, let's say, benefit of extending your antibiotic period post-operatively. Of course, it's not published, but I think Jon Goosse will present it at the EFORT. And I think that's something which is in line with what you're asking, that if you extend your antibiotics, you think you are sure that you will not get an infection. But I'm afraid it's far more than the antibiotic. It's the host, it's the surgery, it's the soft tissue envelope. And the reason we give let's say, the antibiotics a little longer after surgery, because it makes us feel good. It's a certainty we look for, but it's a semi-certainty. Huh?
Yeah, absolutely. I agree. I agree, absolutely.
So we changed it now in our clinic from only one gift, just one before the incision and no prolonged antibiotics.
It's better for the surgeon than for the...
Sorry, Vicente, one question.
No.
But if you look it on the other way around, this may mean that prolonged antibiotic doesn't give a damage to the patient. In a way, giving one shot or giving 5 days or 10 days.
Yes.
So that's the other problem. How do we manage to identify the patient which is at risk, and we need to investigate a little bit more in terms of biology, biomarkers?
Yeah, you're right. So it comes back to two things. We know that in the US, prolonged antibiotics is very normal, even up to 2 weeks or longer. And the question, of course, is you get resistance in some of your patients. So if you have prolonged wound healing at day 5 and you already gave them antibiotics for the first 5 days, and you do let's say a DARE at day 7, you might increase the risk of let's say a germ which is non-sensitive for the antibiotics you have been giving. So that's the only reason why we are more, let's say, a little bit more reluctant not to give a prolonged antibiotic period. But to be honest, my career of 25 years, I was very happy to give them the antibiotics up till day 5 to 7 until I knew the preliminary cultures. Unfortunately, if you do an RCT, that the data don't show it, I have to follow the science.
Absolutely.
And not the gut feeling. The gut feeling is always different than the data.
Yeah, but talking about gut and microbiome, we are just
absolutely. So my personal experience is to come back to the discussion. I think it's more about the host than about prolonged antibiotics. That's what I think.
That's exactly what I was going back to. Let's say that probably the main problem is not about the infection on the site, but what we're going to the organ, to the host, so to the patient, and what this prolonged therapy may affect the whole reaction of the body, and this is something that we should go deeper on. So I'll just take the chance to say to the audience, if there are any burning questions, just to put them on the chat, and we will post them to the speakers, and then I'll leave you the discussion back. So Federica or Heist, if you have any more questions to Vicente.
Yeah, I'd like to ask the question about the alpha differencin. I mean, the costs are there, we all know it. And how many people do we think consider using it routinely? Vincente, you always use it?
No.
Federica, you always use it? No.
Not always.
Stefano?
Not always.
Hi, we changed the protocol because before we were using, I'll tell the name. Was the Zimmer Biomet alpha defensing test, which is quite expensive, but we managed to have it a good price. Now we do it straight away in the lab, and this is much less expensive. And we've been we did a study in coupling this with some biofire tests, and we have results that are not totally what we were expecting, but we may discuss it in another situation. But using it at the lab level, the cost reduces quite a lot instead of using the prepared tests that you buy from the company.
But do we agree that normally with your routine laboratory testing and culturing and your PMNs and leukocyte count, with the adequate histology, most of the cases in my practice, alpha differencin didn't make the difference?
If we put together different tests, the synovial test and serum test, the leukocyte esterase, which is very, very cost effective, probably we can address most of the patients. And probably the problem is not to get a septic or aseptic. The problem is to give a name. This is probably the main problem we have. So we're pretty good in, telling, okay, this is septic, this is not. We're not perfect, but I think we are doing quite a good job. We still have to address those 40% of patients with culture negative PJI.
40%.
I would say that probably alpha defense is more another confirmation test more than a diagnostic test at this moment.
Yeah.
That's where you could combine it with the next generation sequencing Vicente was mentioning. Tomorrow, don't you think we're gonna have one tool to make sure it's infected, and then we use the next generation sequencing, which is more costly, but then we use it not for every patient but for this specific patient, and we have information regarding the bug in, let's say, 10 minutes, and then you can make your decision on how you want to treat this patient. That would be probably the next step, I think, thanks to all the great technology you guys are mentioning, don't you think?
But I think that will be the game changer. Eh? The patients, you normally open up the joint and think it looks like an infection, and you don't have the test to actually say it is. That's where in the old days we did a gram stain, which didn't work out very well. So we had to wait, or again rely on your gut and either continue or just stop. And I think for those patients, intraoperative testing with a result in 10 minutes, that would be great.
Would be.
Yeah.
And also for patients who are treated with either a spacer or a girdle stone, where you actually want to know whether you can go back for reimplanting.
This is another thing that is very important. This is a game changer. You already done one step and put a spacer on, and you want to go back on the joint and reimplant it, and you want to be sure you're not going to have a reinfection, and this is going to be something very important to have, and this is probably another part of the path in the treatment of PJIs that it's going to be very important, where these tests are going to be game changing.
As long as it's not false positive, that's the only problem which will occur.
Yes.
The other question I wanted to ask is, with this test, as well as you can have false positive, you can have multiple positiveness. So then the strategy in antibiotic therapy can be quite complicated if you have more than one bug, and try to distinguish between false positive and real positive cultures if you have more than one bug.
Yes, of course. Yes, with this technology, I think in the next years they will be improved this test to increase the specificity, because if they give us information, not good information about the etiology, they are not valid for do anything. Okay, and what I have learned about this test, they are improving all the time the specificity, and it's what we need to, as we speak before, we need to give some name to the bacteria to know who is playing against us. But I think it's an open question, and I think it's a question of months, years, to develop more techniques. And from the point of view of the biomolecular technology, they are making a lot of improvement in these technologies. We are speaking about 5 years ago, only the PCR, the polymerase chain reaction, was the only option, and every month, we can read another paper from one technology, detecting DNA, detecting mRNA, detecting and make a difference between the genomic material from a lizard bacteria or from an active bacteria, and I think it's a non-stop of increasing knowledge. and we will be there and give and have this information for those cases that, by example, for the chronic cases. I think we don't have so much problem in the acute cases. We have a lot of elements to make the diagnosis and a lot of elements to have really nice cultures of the bacteria that is provoking this purpose-static organ infection. But by example, for the chronic cases or for cases with non-cultured, it's absolutely necessary to improve this knowledge about this technology.
So one question for the three of you. It's a little bit provocative, but it doesn't want to be provocative. It's just to have an idea of, and I don't want you to predict the future, but just to see how much you forecast the future. So when do you think we will not need major and minor criteria or, consensus, because we're going to have real biological, tests that are going to give us, sure indications about the bugs and identification of the bucket infection. So when do you think it's going to be possible to have this and not talking about, give 2 points to this, 1 point to that, and give a real statement on this is infected, this is not?
You're really provocative, Stefano.
Yeah,
yes.
I am.
I think I really have no idea, because I see a lot of people going with this technology. This technology implies not only molecular technologies, it implies informatics, because we need to have a lot of data to have the information of these technologies. And we are going with molecular techniques, but also with bioinformatics. Very important. And to develop all these technologies and to have all this knowledge, it's very fast, but I sincerely cannot say we are speaking about 2 years, about 3 years. I hope it goes very fast and very economic, because I think a lot of patients could be better treated and could be better diagnostic. We can make better diagnostics and we can make better treatments of this purpose-static joint infection. But I cannot say 2 years, 4 years, 5 years, for example. I don't know.
Thijs, what you think?
I think it's a valid question. I think if you look at the last 5 years and all the criteria that came out of different societies, it's a dynamic thing. And the only thing we should not do is follow a test which is on the market, which costs you money and has the same specificity and sensitivity as all the others that came on the road. So be aware, we have the problem that in all registries, the infection, let's say, patients are increasing. So it means that we do probably a good job. But I think the major thing will be prevention. That's one thing. And the diagnostic of a culture negative infection, that will chase us for at least the coming 5 years before we have a test that will take all our culture negative patients out. I think that will not be there within the coming 5 years.
Yeah. And I still think it will be a matter of probability. So we will probably do it better, but I don't think we will be sure at any time in the next future. But
prevention and biofilm treatment. That's what yes. I hope for.
The other key point is biofilm, because actually we didn't talk about biofilm so far, but I think that biofilm is actually play a major role. So do we want to talk a little bit about it? For example, do you routinely use, I don't know, sonication, or how do you usually manage this topic, Vicente?
Yes, when I take the implant, I go with sonication and to make the culture of the fluid of the sonication. And as I said before, I think biofilm is important. It's very important to achieve a diagnostic in not too much time, because the biofilm is dynamic. and biofilm increases and increases and increases. And if we procrastinate and we take too much time to make the diagnosis and to make the decisions, then we can do anything more with an implant that can be treated, by example, with a dial. And it's a question of time. If we suspect one septic problem, we need to go fast, very fast.
Yeah, it's not about months, it's about days. So it's about hour biofilm formation.
Hours. Yes.
And do you have an experience, because not all the hospital may have sonication or dedicated lab for this? Do you have any experience, for example, about DTT or other instrument you can use instead of sonication for those who work in an hospital which don't have the possibility to do it?
I have this possibility of sonicate implants. Of course, I sonicate when I make a 2 times revision. I sonicate all the cement of the spacer.
Okay.
It's sometimes you have not so good feeling for this sonication.
Well, to be honest,
you feel it's
we did sonication for a while on both our hips and knees, and then we looked at our numbers compared to the intraoperative cultures and histology, and unfortunately we didn't find that the contribution of sonication was that good, so we abandoned it.
And what about what Vicente was mentioning about PCR of the sonication liquid? Do you see a place for this kind of exam?
No, it means that you have to increase the diagnostic tools when you do sonication, but just culturing of sonication is not better than adequate culturing intraoperatively. But if you do PCR and other techniques like we have discussed this evening, then it might be beneficial because you have just more material to do your investigation on. And that's the reason why the whole sonication started.
Yeah, that's exactly my point. So we may have some, richer field of material of, experimentation and.
But then again, you should keep it for the culture negative infection patients. The
last burning question, because we have 2 minutes left, and it's: do you think that with the means we have at the moment, we can break the biofilm? I'm talking about these lavages that are now available from the industry, like scratching the implant, like washing the implant, like we do on we try to do when we do Dyer, for example. Do you think we really break the biofilm, or we have success if the biofilm is not there yet? Very quickly, answers.
I don't believe there's one technique which has evidence that it's supportive to be the golden standard for breakage of the biofilm.
You mean to use toothbrush, like
Yes.
Exactly.
I think it's the same question that give for 5 or 7 days antibiotics. It's a treatment for the surgeon, not for the patient.
Yes, I still don't think that solution in commerce actually may play a role different instead of betadine or peroxide oxygen or anything else. So we still don't have a perfect solution, but there is a lot of pushing on this topic. So
I think time is up. I like to thank you all very much. It's been a great edition of this hot topics, and with a great topic. And I'd like to invite you to the next one, which is going to be the last one before summer break. It's going to be on June 17th, and it's going to be about the valgus knee. You will soon receive an email with an advertisement about the speakers. So I thank you all, and have a good night, have a great week and a great month, and I'll see you next month. Thank you very much.
Thank you. Bye-bye.
Thank you.
Bye-bye. Thanks a lot. Bye.
Thank you.